Hi. I'd just like to start off by two things. One, of course, so I'm going to discuss the opposite role, that there's no reason to intervene early in CLL patients until we have a proven survival benefit for our patients. Here are my disclosures. And what I'd really like just to start off by saying, and some of this, of course, came up while I was listening to Dr. David's presentation, is the idea about, there are three types of lies. There are lies, there are damn lies, and then there are statistics. And I really actually had to get, the reason why that came to mind was because we're going to be presenting probably a lot of the same papers. And it's sort of interesting how the two people arguing the different sides of the same issue are presenting the same data. The other thing I do want to really remark on, which I think really is the single most important feature that we all have to keep in mind when we speak about prognostic markers, is the idea that, and this is a quote from Sir Arthur Conan Doyle of Sherlock Holmes fame, that man is inherently unpredictable, except in aggregate, where you would know through the use of statistics how an entire population will behave, but never the individual. So no matter where you look, you're always going to see someone doing well on the curve that's poor prognostically and someone doing poorly on the curve that's good prognostically. And we can never know where on the curve the individual is going to be. And I just can't emphasize that enough. So one would think, looking at this curve that I'm showing, which is actually a list of CLL patients over the decades from MD Anderson, that we're really doing a great job in our taking care of our CLL patients. As one could look and see, it looks like that we're having an improvement in our overall survival, decade to decade. But of course, and this is a different population of patients, this is a study out of Europe using Binet stage, the improvement in prognosis or median survival that was seen with these patients was almost completely due to basically the earlier diagnosis of patients. So this shift towards early diagnosis can be seen here, where in the 70s, 26% of patients were Binet stage A when diagnosed, and by the time we got into the 90s, that was up to 72%. And you can see a very dramatic improvement in our median survival with really nothing more than early diagnosis. So in a way, this is a little bit of the question that we're already asking ourselves. So if we do diagnose patients earlier, is there any advantage to early intervention? And the answer is no, because these patients diagnosed earlier, the entire benefit totally due to the lead time bias from the early diagnosis, and stage for stage, there's no difference in these patients' outcomes. So therefore, early diagnosis does not lead to a better outcome, and I'm going to extrapolate that to the idea that early intervention doesn't help these patients either. So let's look at what examples we have. So here we have chemotherapy, and this is the original study that was done looking at chlorambucil versus immediate versus deferred treatment with chlorambucil plus prednisone, and we really find no absolute difference in overall survival. So a lot of this is what we currently still use in 2017 to justify our watch and wait strategy. But it's important to remember that not only is chlorambucil a not so effective agent, it's also not that toxic of an agent. So let's take a look at what we now currently use in terms of FCR chemotherapy. So here we have the FCR 300, which are 300 consecutive patients treated with FCR chemotherapy at MD Anderson. And what you could see are two curves, the PFS curve down here in blue and your overall survival curve here in red. And one would look and say, hey, we have maybe about 30% of our patients who are at 10 years free from progression, and perhaps those patients are cured. But let's take a closer look at these patients. And what we see is that the majority of these patients are actually mutated patients who are probably likely to have done well with almost any therapy that they were going to be receiving. So this is really why we need to have good phase 3 data, because the idea is these patients would have done well probably regardless of what they got, and for you to say that it's the FCR that enabled them to be free from progression at 10 years is really, it's true, but you can't really say that without saying that it's not something else that would have been accomplished with any other agent. The other thing that we have to keep in mind is, this early intervention with FCR chemotherapy really has a high cost to our patients. So here we see Richter's transformation in 8% of patients, secondary hematologic malignancies in 6.3%, other cancers that are excluding non-melanoma skin cancers, so real cancers, 21%, 71% of deaths in first remission, and 40% of the deaths were associated with secondary solid tumors, acute leukemias, MDS, and Richter's transformations. So I agree with Dr. Davids that, yes, FCR is very toxic, and that here there's a lot of potential reasons to delay therapy. We do know that that might not be true for Ibrutinib, and so that's going to be the important question. Here we have our phase 2 data. These are the 5-year outcomes that were shown by Susan O'Brien at ASH this past year. And what you can see here is these are the treatment-naive patients that received Ibrutinib as their frontline treatment. And you can see an amazing overall survival and a remarkable progression-free survival with these agents. And so one would think that what else could you need? But just like we saw with those patients at the FCR 300 who did remarkably well at 10 years, the question is what would a lot of these patients done regardless? And so that is one question. But while we look at how remarkable these curves are, I want to point out that these are also curves obtained with patients who got treatment when they met the IWCLL criteria for treatment. So when all of a sudden you're asking about early intervention to improve outcomes, this is sort of the baseline that we're dealing with. And so the question is A, could you ever improve upon this? And B, is it really necessary? And that's especially important with regard to all the potential toxicities that we see with Ibrutinib. And certainly Ibrutinib is, relatively speaking, a well-tolerated drug, but we certainly see a lot of issues with diarrhea, bruising. Actually, there's been reports of intracranial hemorrhage, which could certainly be life-threatening. We see atrial fibrillation, which is currently at about 10% and is likely to increase as it is a cumulative effect. We see hypertension at about 15% at year 5, and that's also something that's likely going to increase as as it's more of a late effect than it is an early effect. So we do have a lot of toxicities, and we don't even begin to know the long-term risks associated with these drugs. So we speak to, quite frankly, issues related to basically the impairment of the immune system that we see in CLL patients. Well, we know these patients who have X-linked agammaglobulinemia and have BTK mutations have horrible immune systems and succumb to infections and secondary cancers very frequently. So the question is, are we ready yet to actually make our patients into what might be XLA patients, knowing that the long-term side effects really could be very horrible? And so that's important to keep in mind when we talk about a 5-year PFS is really not something that would be adequate for most of our patients. And while we talk about the toxicities associated with Ibrutinib and the actual lack of proven benefit to early intervention, what I do want to also focus on is something else that Dr. Davids talked about, which is the risk of basically developing resistance to Ibrutinib. So Ibrutinib resistance really comes in 2 types. There's going to be those patients who develop a Richter's transformation, and there's going to be those patients who develop CLL resistance. And the CLL resistance is most commonly going to be due to a single base pair mutation that actually impairs the ability of Ibrutinib to bind to the necessary amino acid. And so this is most commonly going to be the cysteine 41 serine mutation, which was published by Jennifer Woach in New England Journal, or this is going to be the PLC gamma mutation, which basically generates a bypass track. Regarding the Richter's transformation, these are patients who most commonly, as we're now learning, likely have other biological risk factors like a Notch1 mutation or V4-39 mutation, which lead to a very different biology that seems to lead to an increased risk of transformation. And in fact, when you look at the 4-39 or the Notch1 mutated patients, you're talking about risks of Richter's transformations by year 3 of already 30%. So this is a very, very early phenomenon. And we know that the 4-39, because it's the V gene, is present on day 1. And most of the data for Notch1 mutations suggests that it exists on day 1 of the diagnosis as well. So you really have to treat these patients far, far, far in advance of when they might even be diagnosed. But regarding the CLL resistance, the one most important topic I want to make, and this is a paper from Jan Berger and Dan Landau, is that the data currently suggests that the vast majority of these mutations that give rise to resistance to ibrutinib, either the BTK mutation in the cysteine at position 41 or the PLC gamma mutations, and there's 3 of them, really are pre-existing prior to the initiation of therapy. So while you could say that ongoing active mutation might allow these mutations to develop and then grow while patients are on the ibrutinib because these cells and these clones are resistant to the ibrutinib, the data here suggests, and what we have here is basically them taking a look at the individual growth rates of those clones and taking them backwards. And you could see that long before the ibrutinib is started, we have cells that are in anywhere from 100 to 10,000 numbered that possess these mutations. So all of a sudden, even starting treatment earlier, when these mutations are already in existence, wouldn't make a difference, and that these patients are still going to become resistant. So overall, it looks like early intervention is just going to increase the toxicities the patient's going to be exposed to without potentially overcoming what really is the most important issue, namely resistance. So in summary, we know that early diagnosis has not improved outcomes, and that's based upon the data from the MD Anderson and the European data over the decades. We know that there's never been a paradigm in CLL that early treatment with chemotherapy has had an improvement in the impact, in the improvement in patient outcomes. Early intervention is always going to be associated with an earlier risk of adverse events. And with ibrutinib treatment when indicated by current IWCLL standards, so currently doing what we all do, demonstrated phenomenal disease control and eradication. So anything that's going to challenge that really has to be really well justified. Even ibrutinib is associated with significant toxicities, and we talked a little bit about the XLA patients who really do not do well long term. And finally, for those patients who do develop progression of disease on ibrutinib, evidence suggests that that resistant clone is there beforehand. So earlier intervention would not likely have made a difference. Thank you. Oh, and then of course, cost. Forgot I'd put that one in there too. Thank you.